Welcome everyone to today's webinar. I'm Morgan Hafner with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Please be patient as the post-webinar preparation of materials can take some time. It is now my pleasure to introduce today's presenters. Marc Stanislas has been with University of Vermont Health Network and its predecessor systems for 23 years. In his current role as Network Vice President in Treasury and Financial Services, Marc coordinates efforts with network-affiliated CFOs to establish, educate, and emphasize a network financial approach and unified financial standards, reporting, and processes. He is responsible for transitioning debt management, budgeting, cost accounting, and decision support, financial framework development to a coordinated approach with multiple hospitals across 2 states. Walter Morrissey, MD, is the Managing Director of Kaufman Hall, with more than 20 years of healthcare experience working as a clinician, strategic advisor, and administrator. Walter is a member of Kaufman Hall's strategic and financial planning practice and is focused on assisting hospitals and health systems with designing and rationalizing regional delivery networks, clinical and physician alignment strategy, and organizational transformation in preparation for the ongoing transition to value-based healthcare. At this time, I am pleased to turn the floor over to Walter to begin today's presentation.
Thank you, Morgan. Good afternoon, everyone. Marc and I are really excited about the opportunity to speak with you today about integrated data-driven decision-making and how we can optimize our clinical decisions with that data. As you see the agenda in front of you, we're going to spend just a couple minutes on some of the trends related to value-based care, really just to set up our conversation about that importance of integrated data-driven decision-making. As I complete that section and that background, Marc is going to spend his time today talking about what they're doing at the University of Vermont Health Network, what's going on in the state of Vermont and some of their moves to an all-payer model. And ultimately, we'll conclude together talking about how the University of Vermont Health Network has used this integrated data to drive their clinical decision optimization across the entirety of their health network and what that journey looks like moving forward. We'll conclude with some keys to success, and as Morgan mentioned, we're looking forward to taking questions at the end. Marc and I thought it would be great to start with this quote from Jim Hackett, that companies never choose to die, and yet many, by not evolving, are enabling that kind of fate. I get up every day feeling like time can be wasted here if we don't get moving. And given the familiarity of this audience with the trends in healthcare, we don't intend to spend a lot of time on this shift towards value-based payment and making the case for it, but we recognize and want to emphasize that the demands, particularly on the economic side, continue. The competition across our various segments of business, whether it's inpatient, outpatient, physician, or otherwise, continue to increase. And ultimately, we will put forth today this need to drive to the next generation of performance is going to require looking at integrated cost and clinical data. As you look at this slide that talks about the payer and purchaser focus on the total cost of care, we really could have pulled one of many. As many of you are familiar with the Dartmouth Atlas work that really started looking at the variation. These slides haven't made major changes over the years. Whether we're looking at per enrollee spending or Medicare beneficiary spending, we know that variation really is rampant across the country, across markets, and often even unwarranted variation is pretty rampant within individual health systems and hospitals. And ultimately, for success moving forward, hospitals and health systems are going to have to tackle that. We recognize that also there have been some naysayers along the way. The shift to value-based payment, as it was talked about in 2008 and 9, with the Affordable Care Act at times has slowed. But ultimately, we really believe this choppy path that we've seen continues to trend further and further towards value-based payment. And ultimately, given the underlying economics, given the need to take cost out of the system, and really the ongoing competition, the hospitals and health systems don't have a choice but in order to move forward with more data-driven decision-making to ensure that their success continues moving forward. As we think about it, really data-driven decision-making is ultimately a major cultural shift across most organizations. As you see here, executive leadership hasn't really historically spent as much time measuring and tracking on a consistent basis, nor had the ability to cascade down enough analytics to support the operational managers who need to drive performance. People on a daily basis need to be understanding, are they on track? Who's accountable? What are the risks? What are our mitigation plans as we move forward? And really, that hasn't been a strength of our hospital and health system clients. As we spoke with hospitals and health systems across the country, we found that 73% think that the performance analytics play a critical role for the organization moving forward, but only 8% are really satisfied with that performance. And if you extrapolate that a little bit further across the organization beyond just this poll of CFOs earlier in 2018, we recognize through our cost transformation survey across the country that most clients are saying our cost improvements are not sufficient, we don't trust the data, and it could be used more effectively. That's in excess of 3/4 and 90% feel like the current state is nowhere near where it needs to be. And ultimately, across an organization, from the senior executives to the mid-levels, all the way through the analysts, they feel like that desired future state provides a roadmap, has clear initiatives, accountability, timelines supported by reliable data. So as we start to say, what does that mean? This transition from current state to the desired state with a roadmap, accountability, initiatives, measurement, reliability. We really think that has 4 dimensions. And ultimately, this integrated approach to performance management has to hit each of these buckets. The first being enterprise planning. What is the financial planning, capital planning and tracking, budgeting, and forecasting with an organization? We really believe those are the blocking and tackling foundational elements that need to underlie organizational performance. That then moves up into management analytics. What is the right set of performance reporting? What is our productivity and cost management, and how do we compare? Those analytics are critical to providing management with actionable information and comparisons to understand the performance of the organization. That is further supported by costing and decision support tools that allow you to evaluate your contracts, perform service line analyses, and ultimately a lot of organizations have spent time in the first 3 buckets here. But this shift to clinical transformation has been slow and ultimately only recently gaining steam, except across some of the leading organizations. And by clinical transformation, we're talking about combined cost and quality analytics, physician-specific scorecards, identified, not blinded. We believe in really looking at utilization for risk and severity adjusted cases, ultimately compared to clinical benchmarks both internally and externally. This step is really where we move from basic informed decision-making to really driving change in patient outcomes and cost. It is that critical next step. As we dive into the clinical analytics and clinical transformation a little bit more, We really believe it's important for an organization to look both from a global or top-down standpoint, as well as from a program or services bottom-up approach. So as we think about global clinical and quality processes, it's important to address length of stay, observation versus inpatient, care management, patient throughput, on the clinical side, and really how do you drive across the organization. Another example we see a lot of organizations looking at from a global standpoint is, what does our last day of stay testing look like? What does our blood utilization look like? Those organization-wide analyses really start to provide a fundamental lens for prioritizing areas for opportunity. That obviously has to be combined with the quality processes, whether you're looking at hospital-acquired conditions, potentially preventable conditions, or patient safety indicators. We would argue that it's also important to layer on registry data and use some of that outside information that many of your organizations participate in to further align those quality processes. And that gets combined with clinical condition-specific change. All organizations may tackle blood utilization, early recovery from surgery across the organization, mobilization, diabetic control post-op, preoperative antibiotics on a global level. We really believe the organizations that drive the most performance improvement also come from the bottom up and look at things from a clinically condition-specific analysis, whether that's medical, DRG, surgical, or procedural. And this easily expands beyond just inpatient care, but to include the major outpatient, whether it's ambulatory surgery, emergency department, et cetera. But how much physician-specific variation is there within the treatment of risk or severity adjusted sepsis or joint replacement or congestive heart failure compared to external benchmarks and compared to internal benchmarks? Together, that really provides the key decision-making tools and information that's going to be required to be successful in a value-based era and ultimately drive the performance that we hear you so badly need, but to date haven't really had the capable analytic capabilities nor the implementation capabilities to drive success. Over the next bit of the webinar, Marc's going to spend time talking about how the University of Vermont has driven some of that change and how they plan to move forward, taking it to another level.
Hi, this is Marc Stanislas. Thank you for the opportunity to speak with you today about the journey that our health network is having as we go through how do we look at managing data more efficiently and, for the multiple purposes that Walter just laid out. Just a little bit about our health network. We are a 6-hospital health network across 2 states. There's 1 academic medical center, there's 3 community hospitals, and there's 2 critical access hospitals, so we have a pretty good mix. Our annual revenue is over $2.1 billion. We have over 1,200 physicians as part of our health network. We have over 40 accredited residence and fellowship programs, and our non-MD FTE count is above 11,000. Other critical points of information to understand about our organization as we talk about how our health network looks at managing data is I think it's important to know that our health network is all in the all-payer model in the state of Vermont. Just a little bit of background, the all-payer model is for those participating PCPs for Medicare, Medicaid, and the commercial exchange that choose to participate in that program is a fixed perspective payment model for all of that patient activity. That represents about 20% of the total revenue source on the Vermont side. The academic medical center is also in the tail end stage of an inpatient bed replacement building project. So basically, at the end of this project, which is going to be online and occupied by patients either the end of the second quarter of next calendar year or at the beginning of the third quarter is going to bring us to 80 to 90% single occupancy rooms. And we're in the process of implementing Epic across the health network. So I know you're all wishing us luck on that, so thank you. Just as a little bit of background, the Academic Medical Center had Epic as a clinical documentation. In addition to expanding that to 3 of the other hospitals, the health network is also going to implement the front end and the back end of the revenue cycle in Epic. So there's a lot going on at our health network. So this is just the beginning of the journey. When the health network came together, that our approach was to develop a single approach towards reporting and basically have a single source of truth for all of the entities. We started off with the financial and just the pure metrics, and also the other thing I should say too is that 2 of the New York entities are in the obligated group for the health network, and that's the first time the state of New York has ever let a New York hospital join a non-New York obligated group. So we started with a single set of financial reporting from a single platform. Just to share a little bit about our journey, this is some of our key financial metrics, and just to give a little bit of a background is, over the last 4-year period, our health network has been a BBB rated entity. It was upgraded to an A- rated entity, and it was upgraded to an A rated entity. And at least in my mind, as participating in all of those conversations, at the same time, we were taking on certain affiliates that, that created, dilution for us. So it was that single reporting source that helped through all of those conversations, and I think assisted with the rating agencies in, with the 2 upgrades that we received over that 4-year period. So basically, we started off on a very solid financial platform, as you just saw. And as we were thinking about how do we migrate into this new territory that Walter was referring to, our senior leadership, very quickly and jumped all into how do we focus on population health management. Our finances are strong and stable. Now is the time to have these conversations. Now is the time to have these investments. I don't know if we will ever catch up to how quickly it's evolving, but our focus was the sooner you start, the less you're going to be behind. And also the other component that was a very driving force is that the annual expense inflation is outpacing the annual rate change and payment inflation. Our health network has been able to keep up with that the last few years and cover it through additional volume. Those volume opportunities in the future are going to be limited. We've also been very good at maximizing other payment sources such as 340B and specialty pharmacy, and there's going to be continuing pressure on both of those. So I think from our perspective, before there were 2 eyes on managing with the revenue component, and you're never going to take an eye off from managing, the revenue component. But we wanted to transition at least one of the eyes to focus on expense management and how that relates to quality and outcomes of the patients that we care for. And that ultimately, led us into how do we support these various clinical teams and leaders that we have that have to migrate through these, first the decision needs to be made and then it gets handed down to a team to execute it. But, this is just a list of various committees, and, the most important one is the care delivery optimization, AKA, that's the committee that is taking a look at how we are going to be looking at providing services to our total patient population of upstate Vermont and upstate New York, and deciding exactly what locations of access those services are going to be provided in. And that, acknowledging that's in the very early stages, but they have made some decisions in orthopedics, and we are transitioning to some other complicated areas of discussion, mother-baby, ortho joints, and so this was also the other need for our data to support that, process. This is just basically speaking to, the traditional decision support and cost accounting system. Our organization made the decision that is going to serve as the foundation on providing the data sets to this next level of analytics that Walter was referring to. Just as a little bit of background, and this is part of our reasoning, why. Within these 5 different hospitals that came in, there was 10 different billing systems. There was 10 different collection systems. And a lot of effort and work, in which I cannot understate the effort and work that, that went in to make the data as comparable as possible to use for decision making. So, that was our foundational approach. Now I'm going to talk to how that integrates with our overall approach to data management. So this is just a financial slide, that we developed for all of our entities. It is part of our monthly board reporting packet. Well, so we felt that we had a very good grasp on the reporting for the health network from a traditional financial perspective. I will just share a little editorial comment. We found it, very productive to show all of the rating agency comparisons, all the way down to single B+, because as you take a look at the hospitals within our health network, there's very varying profile between all of them. Anyone who works with hospitals on the New York side knows that there's a different set of financial metrics on the New York side. So, just keep that in balance as you look at the New York entities on this grid. So basically, our overall approach to data analytics is, so the first step is we basically integrated the data across our health network through the traditional, financials. We overlay that with a financial planning process that serves as our multi-year financial framework. As an example, when we were planning for our EPIC implementation, our financial framework actually had to be 10 years out because it was a 60-month implementation. And yes, it is difficult to get past 3 or 4 years out, but in the state of Vermont, we have a regulatory board that approves all of the hospital's budgets and the CON process. So that served as a very valuable tool. We stood up our decision support capabilities across the whole health network. Now we have access to payments and costs at the patient encounter level. So next, as we thought about how do we tackle this transformation of information, of taking all of those metrics and kind of marrying it with cost and quality and benchmarks and other measures, and variation between hospitals, variation, between physicians. Okay, our thought was to figure out, what's our single source of data to start with, and our decision was to use our cost accounting and decision support system as that single source of data to feed that clinical management or decision support system, or, just information system, candidly. So to allow us to do this, it really required the partnering between the finance departments and quality, because it is those two pieces hand in hand that I think is going to lay a better foundation for success. So, coming back to the Axiom, or the Axiom / the cost accounting with decision support as a starting point, that was the only location that we had all of this financial and clinical and payment data all in a single location. Well, what wasn't in there was the quality data, or the survey data and other benchmarking data that our quality area uses. So we worked with the quality team and also the vendor to import all of that quality data into our cost accounting and decision support system. The data was not married at the encounter level in that system. That's what we are migrating to. The clinical system that we chose to assist us in this journey of how we look at ourselves was the Peak solution. And then as we thought about it further, Axiom cost accounting and decision support was on the cloud environment. Peak was on the cloud environment. It was the same vendor between both of those software solution applications. So the thought came to us is, how do we work with the vendor to use our cost accounting and decision support data, now that the quality and benchmarking data is in there, and create a seamless transition over towards picking a software solution to help us identify opportunities from a variation in benchmark, from a variation to our peers. And then how do we bring that down to the patient level? How do we bring that down to the physician level? And we use that as actionable data to make decisions about, where certain services are going to be provided in our health network, where currently they are provided, but they may not need to be provided, or the decision is made not to provide them there for a number of reasons, and even potentially look at places that we aren't providing service, but the need may be there to provide the service, and the underlying, financial support is there to support that decision. So that's what we use to kind of migrate into this marrying of those clinical measures and take it into the next level of analytics, as Walter put it, to help inform us, where we need to go, because we feel strongly, and it can be said many, many ways, but the simplest, way, we need to figure out a way to provide the services that we provide to all of our patient base. And there's a couple ways to think about that. We can provide the same amount of services, less costly, or we can provide more services, better services, more informed services in the patient provider doctor relationship as we function into managing the patient over the continuum of the care needs that the patient has. So, how do we take our expense base and provide more? And, quite simply, we needed a software solution to help us at least initiate these conversations and then, go in to make some of these decisions. I will say that we're at the beginning of this process, that we have made some decisions, but the data is flowing across. We have initiated with some scorecards that Walter is going to be talking about. And our intent is to learn from that process, develop that process, modify that process. And that's kind of where we are with our data management. And I'll turn it over to Walter now to speak to some of our starting points that we chose to start with, with a peak software solution.
Yeah, thanks, Mark. I think I wanted to come back to one slide and put it into the context. As Mark talked about the network, he talked about its formation in 2011, coming together over the next several years, establishing a financial platform for success, and really through that monitoring and driving performance, which really put the network in a good spot to continue to succeed. And as its leaders thought about success in Vermont's all-payer model and ongoing pressure for risk here in this state, as well as some of the challenges in operating in New York, they recognized that they needed to go further. And as they thought about who really needed help across their organization to drive performance, they thought about these various groups. Care delivery optimization. We use the term rationalization of services and get ourselves in trouble, so we call it care delivery optimization instead. They knew their service line leaders, both the physician and the administrative leader, needed good data to understand how their service was performing at their hospital, at the other hospitals, and at a physician level. There's regulatory requirements related to ongoing professional practice evaluation, and how could this clinical data inform that process, make it consistent and smooth, and really in concert with finance. And finally, the standard strategic and quality planning, whether it's through their Jeffords Quality Institute, their Network Quality Committee, the organization really felt like it was important to have a standard, consistent approach. And in too many organizations around the country, we have finance and clinicians speaking different language. I'm sure many of you at your hospital and health systems can find the same analysis come up with different answers. Quality department says length of stay is at target, finance says it's over. You can go down the cost, length of stay, etc. It's really important moving forward so you can inform all these leaders within your organization to inform them with the same data, and that consistency of platform and sole source where you can combine quality and finance was what enabled them really to take these teams to the next level. So to get into a couple examples before we take questions, the first I'd like to talk about is this example here. This is a simple scorecard, physician specific, for hip replacement. So we've gone into the orthopedic service line, down into the clinical condition of joint replacement, into the specifics of hip. And really, as the organization went forward, they wanted to, number one, have enough information to reduce unwarranted variation. How do we increase quality and cost? And they ultimately wanted to be able to inform those macro decisions that Mark talked about. Should we be offering services? Where? To what scale? And now you could create this same scorecard, and instead of having Dr. 1, 2, 3, 4, 5 down the side, you could have hospital A, B, C, and D and make the same types of comparisons. But as you'll see on the scorecard, as you go from left to right, there's some standard things that you need there. Volume. How many are there? Volume, particularly on the procedural end, is shown consistently to drive cost and quality improvement. What's the severity of illness? We all know that physicians complain their patients are different, and you're not judging me equally. So an important risk or severity adjustment factor is going to be key to your success with this. We then move into some of the process type measures. How's your 30-day readmission rate? How's your length of stay? What's cost per case? What's supply cost per case? What's pharmaceutical supply cost? What's complications? So really, we've created this doctor-specific scorecard that has standard quality, outcome, and cost measures. And when you look at the first blush, the University of Vermont really performs really well when they're benchmarked to other external academic medical centers, as was the case here. You can see an awful lot of green on this screen, and typically that shows an area that you're really performing well. But as the organization knew that its overall cost of care was low and would benchmark favorably, they wanted to move beyond just this external benchmarking to understand how their physicians are doing, but really to more internal benchmarking. And if you take one quick look at this slide and look how much green is on it, and we move on to the next slide, and all of a sudden we pop up to a lot of red. And this is essentially the same slide, same doctors. You'll see those volume numbers are consistent as they were on the prior slide, same complication numbers. But really what's changed is those length of stay, cost, supply cost, and pharmaceutical costs. And really what this has enabled them to do, and in this case, the health network here decided to benchmark to the average. So across all those physicians, across all those risk-adjusted cases, what's the average cost per case? What's the average supply cost? And then started to show where that physician is, how they're performing relative to the benchmark internally, and how much opportunity is there. A couple thoughts here as you take a look at this. You've seen there's length of stay opportunities and still an opportunity to drive best practice. You see the costs have changed, and we have inconsistency and variability in performance from all greens to some reds. And ultimately, as UVM's on their journey here, they've started with benchmarking to average. As you take that next step on the journey, you start benchmarking the best performers within your own organization. And with this simple scorecard, an organization can then decide where do they want to deep dive. Why does Dr. C have a pharmacy cost opportunity? What's their supply cost? What's driving that? The idea is to have information that goes down to that encounter level, that we just don't know what the pharmacy costs, but we can go look and say, all right, how much liposomal anesthetics are they using? How much IV acetaminophen are they using? Is this antibiotic selection? The supply side is pretty evident in a hip replacement case, but really to dive into that cost opportunity, understand, is it supply, is it pharmacy, is it length of stay, is it lab, is it imaging, and really start to compare internally. And then that my patient are different story really doesn't quite hold as much weight as it might when you're comparing to an external benchmark. So as you think back to the areas that the health network wanted to drive performance and provide information, back to some of my early comments, 95% of organizations think they need great data and 8% feel like they actually have great data. The idea is to have these type of reports provided to service line leaders, department chairs, some of the health services leader, and ultimately the hospital and network administrative and executive leadership, so you can see how they're performing, update this data at least monthly, if not more often, and ultimately monitor and track performance as you pick specific initiatives, whether it's on the supply side here or the pharmacy side. But ultimately, this gives your managers an opportunity to monitor and track performance and allows them to be held accountable for the initiatives that are underneath them. The last piece I wanted to cover on this one, before we covered one more example and wrapped up, is the importance of really taking this to best performance within the physicians. As a physician myself, I feel that I always say that doctors want three things. They want a learning environment, they want meaningful work, and they want fair compensation. And I know, while I guess some of you may argue about the order, this type of data really provides an opportunity for physicians to get into that learning environment and understand, why is somebody else's length of stay better than mine while their complication rate is lower or higher? What are we doing? And as you think about those volume factors, the average severity of illness or SOI, you can really work with your doctors to answer some of those questions, and ultimately that creates that learning environment that they so crave.
And I think I would add that I think the ability to show this at the high level, but having the system that you can quickly drill down into this at the patient level, help to get our physicians there a little bit more quickly versus just showing them high-level aggregate data. So the ability to navigate quickly from a rolled-up report down to a very specific patient, report was very helpful in our process. I mean, basically, I think that Walter was very polite, but, this transformation isn't going to be possible unless the physicians are on board to the process and they buy into the process.
Yeah, absolutely. And that starts with good, consistent data. So one last example is related to a typical supply challenge. As many of you can probably imagine, the organization started to look at stents and stent types, which we protected on the top chart here. But as you can imagine, for their PCI patients, they were using 5 different stents. We looked at how many each one was being used and what was their cost per case. And ultimately, as many of you can imagine, there's arguments, well, mine's better or mine's better than his or hers, and that back and forth. And ultimately, this tool, as you can see, then started to look at, well, how did the physicians perform? Which type of stent are they using? How do their statistics map out, whether it's severity of illness, which I know someone was asking what SOI stands for, so severity of illness, that's a severity adjustment factor. But how does that compare? And ultimately, how do the individual stents compare? And this allows you to make informed decision-making, whether it's around stents, whether it's around hip supplies, whether it's around pharmaceuticals. We see an awful lot of argument these days or discussion about the use of IV acetaminophen or IV Tylenol, reducing the use of opioids and reducing length of stay. And you can go out and answer these questions by physician, by type of drug. And ultimately, this ability for an individual service line leader, in this case the cardiovascular one, to dive deep is the type of information that needs to be put in front of physicians to drive behavior change and ultimately drive the cost and quality improvement that the network's looking for. So as Mark and I wrap up, we wanted to spend a couple minutes on the keys for success, and then we'll open it up to questions. The real question is, how do organizations embrace clinical transformation? And really, what are the advantages of that? The data consistently shows the cost savings, the avoidance, the growth, revenue growth through improved performance, through new cases and reputation, or whether that's through value-based arrangements that reward you for your high performance, ultimately giving you a competitive advantage. We really believe that future success is going to be dependent on driving clinical transformation. Most organizations around the country have done the low-hanging fruit. You've worked on your supply chain, your revenue cycle. You're trying to maximize your labor efficiencies, shared services. But this has, until the last 5 years or so at most organizations, been the third rail. And really, this is going to be critical as the next frontier in cost management and performance improvement. And we're really excited about the ability of organizations to take what's previously disparate data, connect that data to create a single source, and ultimately have the finance offices and the quality offices in lockstep driving organizational change. So, I think we've got some time for questions. Mark and I did manage to finish on time. I see some of your questions popping up. I know Morgan's going to get started with them. So Morgan, if I can hand it back over to you, why don't you start with some of the questions that have come up?
Absolutely. Thank you, Mark and Walter, for that fantastic presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And you're right, there are lots of questions coming in already. One audience member is wondering, do all of your facilities share the same costing methodology, and they're asking in terms of RVUs versus RCCs and actual costs.
Okay. We made the decision to, and this decision was made centrally, and while it may have been open for discussion, it wasn't open much, but all of the costing is done the same way across the whole health network by department. Some of our challenge, was they were on different GL systems, they were on different billing systems. So we did have to find a way to normalize, that process. But basically, to start, everything is done on RCC at the department level.
Great.
Thank you. Oh, sorry, go ahead.
No, I think Mark got that just right. I didn't have anything to add. Thanks, Morgan.
Great, thank you. And the next question is, an audience member is wondering, will you be doing the same for other hospital services, such as outpatient rehab?
I think our recommendation is that organizations try and tackle 2 to 3 of these items or conditions or efforts per quarter, depending on the size of the organization and their ability to drive change. Obviously, that can increase as it becomes more culturally acceptable. Outpatient rehab, ED, outpatient surgery, other clinical conditions, I think they're all on the list. What we'd argue is that you need to take a comprehensive look and assess where your opportunities are, and then begin to prioritize and sequence those opportunities based on physician engagement, the magnitude of the cost impact, the magnitude of the quality impact, and ultimately likelihood of success. I think that the health network, Mark would say, has picked areas where they've got the physician alignment and executive bandwidth to drive some of the change, and they want to get some quick wins.
Yeah, and start with an easier case, not a very complicated case, because it is important to work through the mechanics of the discussion, the discussion process, the engagement process, the decision process, and then how do you roll the decision out across the whole health network. So, we started with, none of this is easy, so just put that in that context, but, some of the easier components to establish those processes, to establish some working trust between those management groups making the decision across those processes. And then, we are in the midst of the joint discussion and the mother-baby discussion, which are very big discussions. And then, well, like Walter said, you don't want to be dealing with too many of these at one time. But at the same time, what we are doing, we are developing our service lines at the outpatient level, and we are partnering with an academic entity on the logic to do that, and we were able to repeat that logic in our Axiom cost accounting with decision with support system. So as the entity is ready to transition to new areas, the system is at the point that the data can be rolled up and consolidated at the service line level. And then the other thing that I didn't mention, also in our cost accounting and support system, is all of our physician data. So it has all the hospital data, inpatient and outpatient, and all of the physician data.
Great. Those are just some excellent action points and examples from both of you. I really appreciate it. We have another audience member who is wondering, do some of your physicians access the system and do their own analysis?
No.
I would just say you guys haven't gotten there yet.
Yeah, well,
they've got someone to do it for them.
But we haven't got, so I would say that, we are at version 1.0 or version 2.0, and the way it is managing right now is that it is very, very, very limited direct access to the system, and there is a set of standard reports that we've developed. It is standard set of reports. So whenever there is a request, the data comes back in 6 different reports the same way for every request, and then we modify it, from there. Our goal is to get to more direct access, but that direct access would probably be managed to the quality departments first, and then expanded to the physician level. That being said, that physician's scorecard, as it's being developed and shared, that's an exportable report that we want to go to every physician.
I think it's a good practical answer, Mark. I would add that it's not a lot of organizations where in the trenches physicians are spending the time within the system. Usually they're paired with in some sort of dyad model where they have the support and want to read the reports. It takes a special doctor, and I can make those jokes, to take the time to spend in a typical system.
And that is, that special or the unique doctor that can look at the data from a very subjective perspective, from an educational perspective, and from a development perspective, was very beneficial to our process because when we developed those 6 to 8 standard reports, we actually worked with a couple of those doctors that could help us develop it, and I think it was very beneficial to the doctor, and the doctor was in orthopedics, by the way, and it was very beneficial to us. So when we chose to start with those 6 to 8, reports, that we had a lot of confidence in the data, and we didn't try to over-market the data too. We picked the data elements that we had the most confidence in, and we said, let's start there and let's expand on that. Once all these other processes get set up and you start to establish that factor of trust in the data.
Just fascinating. And I have another question that really ties right into that. Do you have acceptance of the data in terms of data quality by the medical staff and leaders across organizations? And did you have any struggles with that at the beginning?
So, I've been with the medical center now like 23 years. I spent my first 10 years or so in the medical group. So, I'm not sure that you always get all of the physicians there to accept all of the data. Okay, but our starting point was our senior leader of quality basically said, this is the single source of data. This is what we will be using. And everyone needs to jump on board and figure out how to make it work, okay? And how to make it most successful, for the decisions that we have facing our health network. So by that physician taking such a strong stance, and then we had some other senior leader physicians, support of that, it closed the door on a lot of that back and forth process that at least what I was used to engaging in. So, the focus is they still challenge the data. We still need to get certain key physicians in comfortable places, yes. But the focus of how you use the data, I think that everyone is on board, at least conceptually, and we still run into the same set of questions, don't get me wrong, but the process has, really narrowed how you deal with those questions, more quickly, and that allows us to get to the more meaningful, work. We still need to deal with it, but, strong physician leadership saying, this is the approach that we are taking, get on board.
Excellent. Thank you for clarifying that. We have a ton of questions coming in, so I'll go on to the next one. An audience member is wondering, what sources did you use for the cost and quality benchmarking information?
So I think that there's a couple questions there with the cost and quality. You know, there's obviously a fair amount of quality registry data. There's the core measure data. There's patient safety indicators. You can compare your rates in the Medicare databases and do Medicare benchmarking, or you can use all payer databases. I think there's a little bit of an emergence over time of customized databases, but really I think there's an important framework when it comes to external benchmarking. And I saw this pop up in a couple of the other questions asking about cost accounting similarities and consistencies when you're using external benchmarks. And the framework we like to use is that external benchmarking is a compass and your internal comparisons are your GPS. So those external benchmarks are nice and they point you in the right direction, but really to drive the performance change you want and that we find real opportunities within the variation in each organization we're in is start doing some of those internal comparisons. It's the same cost accounting methodology. It's the same consistency of quality reporting. We don't hear arguments about people gaming the quality or CMS measures or otherwise from a quality standpoint. It's your data, it's your system, and as Mark said, once you have a physician lead who says, we've vetted it, we're your executive physician leaders, we're going this way, that's where you get the power.
Right, and I really like that analogy with the framework and compass and GPS. It really hit on the head. Well, we have about 1 minute left. So Mark and Walter, do either of you have any final thoughts that you want to share before closing today's webinar?
No, we'd just like to thank people for joining us. We see a lot of you are still around. We think this is something that really makes a meaningful difference in patient lives. So we're excited about it and happy to connect anytime in the future. Thank you.
And just remember, it's a journey. And when you take what you learned today and you evolve it and develop it tomorrow. So thank you very much for your time and allowing us to share our story. Thank you.
All right, this brings us to the end of today's program. Thank you to Marc Stanislas and Walter Morrissey for your insights today and our audience for participating. Enjoy the rest of your day, and we look forward to having you join us for future webinars.